connettiamo tutto. Okay, we put them in the position and comfortable. Usually, when we connect half link, we put the bolt anteriorly, or we use this mark, anterior part, and we put it in the, okay. And the rods will be maybe 4 rods, 90 degrees between them, but it will be not in anteriorly, it will be in oblique position. Maybe fifth hole from the lateral side, and we'll see later what we do in the now we put maybe only 3 rods, because this rod we put later, because maybe it is influenced to the position of these half pins. Okay, what we do? Okay, put the rings here on the patient. Okay, this is lateral. We don't do now the don't do again the medial anterior rod. Better we put two rods posterior. Quinta, anche un'altra barra. Sì, già caricate. Dove? Ah, 150. Ok. Ho capito. Non vedo. Okay, it's an easy job. Obviously, we may prepare it in advance, or nurses prepare it, and we connect it now. Okay. All of them parallel. This patient, we don't do so big frame. It is positioned and distally enough. Like my colleagues showed you today, we have only one patient, one complication, that we put the frame like this on the patient with Ilizarov joint dislocation. But we have 1 half pin here and 3 wires. But the patient was too heavy. He walks too much because he broke the tibia and the mid-shaft. A really rare complication. One time in my life it's happened only. Okay, now we start putting the wires. Usually we start with the first wire from lateral, but we use olive wires. Yeah. Okay. And we start with the wire from distal wire, more distal. We put it in from fibula to tibia in this way. I need one piece of paper or something. Okay. Perfect. Okay. Okay, we maintain this. Alignment. In the first wire, we put distally, and this wire goes from the fibula to tibia, from lateral to medial, from posterior to anterior. It's safe zone, like Alan said. If you put it 3 centimeters, we are outside of the joint. It's not interarticular wire. and it should be parallel to the ring. I keep this. Okay, we cut the skin, olive wire goes inside, and this olive wire guarantee us the good stability and protect the syndesmosis, because if you correct the equinus deformity of the calcaneus, this prevented the enlargement of syndesmosis, distal part. Okay, cut the tip obviously immediately. Okay, and now I keep the rings, and my assistant start to attach the wire. Obviously, remember that maybe a little bit, because the soft tissue and the muscles, posterior part is much bigger, and anterior part we may put really near of the skin, like this. Okay, now we look at how this is going. It looks good enough. When we do deposition of these wires, always control these rods is parallel to the tibia, and we should adapt the position of the wire with the bolt. And like you see here, I see that my wire does not touch the ring, and I use a washer.
2 millimeter or 4?
4 maybe. 4 millimeters washer here. And the way the rings maintain the parallel position, like this. Just a little bit up. Okay. Now for simplify the continuous job, we may put another wire and this non-olive. This time maybe not. And now we put this wire. It's not so difficult because I prefer again to use that wire and go through the fibula and tibia, because it's not so difficult and more stable, and it's safe enough for us. Maybe now to squeeze it a little bit. I put the wire. After that we attach the bone. Okay. Keep it by hand. Okay. Maybe like this. Keep it. And then motor. Yes. Okay, now we put this wire. To maintain this parallel position, you touch the ring, close one eye, and use another one for control the parallelism. Okay, now we are fortunate, it is good, and touch the ring, and it's easy to attach the wires. Here, another one for me. Okay. Now we have an orientation, just good enough. We cut. Yeah, you know there is a different way to put in attention the wires. Many people, or quite always, prefer to use a tensioner. but in the real life more frequently we use the Russian technique. If you want, we will show you how it functions. Okay. We tied the wire from the olive side, and this from fibula 2. Okay, we tied this.
Keep it on the same way.
I just hold it.
How we do the tension here, or you do? Okay, assistant keep the rings. This is like we call it Russian technique, because we need to rotate the bolt and the nut simultaneously, but much faster we do rotation of the nut, like this. And this way the wire is good in a good tension. It looks not so secure, but for sure I know we measured the tension. You may do this kind of rotation and achieve the tension 130 kilograms without any difficulties.
Yeah. Dr. Kirienko, as you move along, I would just have some questions. You still move along.
Yeah.
So you tension those wires. If you have two wires, usually we put two wires.
Yeah.
And if you have put two wires, do you tension at both at the same time, or you tension one after another?
No, we tension one after another because we know that, like this way, you see this wire, we put it distally.
Yeah.
Another wire I will put from above the ring.
Yeah.
And when I do the tension of the second wire, the first wire, if I have a good enough crossing wires, it is compensated, and the first wire will not lose the tension.
Okay.
No.
Does the angle make a difference? Your 30-degree versus 60-degree versus 90 degrees?
Yeah, we don't do too much crossing here, but 45 degrees by mechanic studies, if you do a 45 degrees crossing, it is a perfect way to obtain the good
Okay,
tension.
okay.
Okay, now we do the same here.
Is your Russian tech...
Theoretical way, theoretically, obviously, maybe if you have this condition, you may do the tension simultaneous, two wires or with a tensioner. In traumatology, when we do surgery for trauma, we never use Russian technique because in any case here, the wire just a little bit displaced and you risk to displace the bone. But in this, how we may say, orthopedic practice, it's not so important.
Sure.
Important things to achieve a good alignment, like you see, we position two rings now positioned. It's now other steps. It will be not so difficult. Okay, now we put another olive wire to the medial part, to the tibia.
Do you always prefer to use olive wire versus smooth wire in the tibia shaft?
In this case, yes, in distal part, because probably I don't put the olive distally. We don't need here, or we may use one olive or one half pin here, but usually we prefer to put the wires. Maybe for more stability, we put 3 wires. If you don't want to use only wires, we may put, like we do this, one half pin. Now maybe we do it differently, even show the possibilities here. Okay. In the olive wires, one from the medial part, another from lateral. In this way, like you show later, this olive prevents the slipping of the ring, because the rings with olive on one side or one from another side, the ring can't move. And with this good stability, we guarantee stable frame for a long time. Important is to have a really good stable frame. and to tighten the nuts, to tighten the bolts, everything should be done mechanically perfect.
What specific tune, when you judge the tension of the wires, you listen to? Right, I feel like this is a little bit more subjective. For you, you have done many years.
Yeah.
What are you looking for? What kind of a tune you feel that's enough tension?
Enough. The first thing is that when you rotate the bolt, it should be rotated, I think, minimum 45 degrees.
45
because
degrees.
If you do it only 30 degrees, no tension.
Okay.
45, 60 degrees. The first thing. The second thing, important that before rotating, you should tighten it really good. Quite completely. You tighten it, and now you start rotate all together, not in the bolt. You continue together, like I said, maybe 45, 60 degrees. And last step, tighten it. And you feel it. Because you see, all two wires maintain good tension. And this ring never shifted.
Sure.
No. Okay. Bene, no, dopo.
Non ne serve.
Okay, now we should improve stability again. We do maybe 1/2 pin here, 1/2 pin or 2/2 pins like we do this. We'll try to repeat this the same frame, okay? Now what we may do, now we usually in our practice, because the beginning patients stay like this, in some kind of pillow, we use this one. But when we did this, when we have this just not so bad frame, what we do usually use some kind of half ring or 1/5 of 8 ring, and we attach this to this support, like kickstand, call it kickstand. We published one article about this kickstand. That's really useful.
I saw that one.
Yeah, really useful. Like this. In this way, practically, we don't need. We have one more assistant because this keeps the leg of the patient in the right position and the patient never moves. Okay, now we do this job. We may start here, or we start maybe this way. Okay.
I'm sorry.
Okay. What we use, like we talked about safe zone, and we need to, for drilling the bone, tibia, we always use this kind of trick, like we use cube, or you may use half pin bolt, something, but usually we use this one whole cube. In this way,
So Dr. Kirienko, you use that as stopper?
Stopper, yes.
Yeah.
Some kind of stopper. This way, we prevent penetration of this drill deeply. Like you see for now, yes, I do. I penetrate one cortex, okay. After that, we fix this ball, this cube. In the, we fix it in the distance plus minus, like we know that the cortex will be. It will be maybe 7 or 8 millimeters. Now I do this, or maybe this bone it's not natural, but like you see, I arrived. Okay, my bolt touch it, and I penetrate. I feel that I penetrate the second cortex, and I stop. Okay, remove it. Okay, you see exit. And after that, we use this. We use conical, or this case it is the half pin with hydroxyapatite. And we do this job by hand because it's much more secure, and you feel penetration of the second cortex. Because if you do it by hand, it's really easy because the first cortex you go, the second you go, and this half pin is you feel that when you finished how to say to do a small rumor inside, it means you pass through the second cortex. But it's always a sensation that you achieve after 2-3 precision like this. You feel really easy. Okay. Now we fix it with okay. We use big wrench. Okay. Fix it really good. This bolt, we better to fix with a right angle wrench because it should touch it, the bolt. If not, if you use normal, it may be a little bit bended and you risk to break it. Here is better. Okay. Again, fix this. Okay. And now we do another one, like we repeat the same precision here.
So, Dr. Kirienko, do you always prefer pre-drill instead of self-tapping, self-drilling?
Yes, in these cases, because I have time and I do a good job, but always pre-drilling. In the offices, always. We don't pre-drill in half pin, maybe only sometimes here in the calcaneus. In calcaneus we do by freehand, but in the diaphysis, no. Okay, put by hand. Yeah, just because we may do the how to say, some kind of experiment. Because when you use self-drilling half pin, what's happened there? I explain you better now, maybe with half pin. Okay, fix it. Need the bolts, short bolt. Fixed again, this. We don't cut them, usually we cut with a big cutter, but we don't cut. Maybe we save the half pin for another, for another workshop. Okay, now obviously this part is really good fixed. And what I want to show you, maybe you experience big enough, but many times maybe it's not recognizable. For example, this half pin, or yes, self-penetrated half pin like this, because it's designed really good, perfect diameter and everything. It looks so nice. Theoretically, yeah. But what we see frequently, for this reason, lastly, we don't use quite self-penetrated half pin in a hard bone, because what's happened here, I show you maybe here in this area, we only for understanding. What we do the penetrating the first cortex like this. Okay, we arrived here. Now I need to penetrate the second cortex, but the second cortex is not going in the velocity of how this kind of how to say the thread. Thread, yes, the thread. It's not it's a very big step, no. But the penetration of the second cortex is impossible to achieve immediately. You rotate it. Meanwhile, you rotate this. Your second cortex, this first cortex, will be destroyed because you can't penetrate the second so easy because it's hard bone. In the first cortex, no more valuable. It's not keeps like before. For this reason, we never do this job like this. We do self-penetrating. Now returning back. Okay. In this situation, we may use maybe two holes cube. I take it. Then we put here. Right. Okay. The same principle, we use this stopper for limited penetration. Okay.
Exactly.
Oh, I go a little bit down like this. Okay, go. Okay, I think. Half pin. Practically, when we do this job, we don't use X-ray or controls of fluoroscopy because you feel the second cortex and you never go deeper. And it's this kind of job is secure and there is no dangerous of damage something. Okay, now what you will. Okay, stable frame. Now we fix it again with a small short bolt, 10 millimeters. Yeah. Before we use big cubes, but now we ask it, Alessia, to produce a little bit small cubes because it's much more compact, and we use range 13 millimeters because this cube is 12 millimeters and a half. It's really comfortable and we save many holes for putting another wires on half pins. Okay. We fixed it, and now, like I said before, we put the fourth rod because we didn't put it before because we don't know again where we put the half pin. Now we found the three holes and we connect the two rods with this fourth rod, threaded rod. Here we found this place. Okay. And now we do this connection. Yeah, this wire, historically, I prefer to keep it. Somebody knows that they broken the wires. You may broke it by hand like this, if you want it. It's possible. If not, we may bend it with a plier. We may use this one to bend it. Usually we do the bend it. It's 3 steps. 1.
Thank you so much.
2.
You have the plier if you want.
3. Okay. We do this job in the way it's not traumatic for our hand. One time we bend the wire, what we do? Because this model, so keep the foot in a normal position. But what we should do, we should simulate how it is in real life. And in real life, like I explained you, calcaneus is always in equinus position. because the patient walks and in the more than 4 foot, and the calcaneus became in equinus. Sometimes we need to do Achilles tendon lengthening. Now we fixed it in this position, how the patient presented in the operation room.
Or also for us in the future is to build a library of all those different configurations. A library, just taking as many pictures as you can out there. Library. Model.
It's enough. But after that we remove it, yeah, it's enough. Okay. What we do now, because the deformity on the Lisfranc joint dislocation in the level of Lisfranc, and we support that the talus and calcaneus is not deformed or don't have a deformity or don't have arthritis. We need only positioned calcaneus in this normal position. What we do here, like I showed you before, we need to do a correction of the calcaneus. And how we do this? We apply the distal ring of the calcaneus in an equinus position. You remember anatomically the axis of the calcaneus and the horizontal plane inclined in 18 degrees. And then what we do, we look at how the calcaneus looks, and we do a little bit more inclination, maybe not 18 or 20, 25, because when we force it, we lose a little bit of this inclination. What we do now, we put in the wire of the calcaneus, like we do there. We use only one wire and 2.5 pin. It will be easy for us to apply the frame. Yes, if we have a deformity, varus or valgus, we'll see it, and we put the olive wire again until. Okay. It depends on the deformity. In valgus, we put the olive wire from external. If for varus calcaneus, we put the olive wire from medial part. Okay, I look at how this is. Yeah, we use the posterior part of the calcaneus. We don't stay near of the malleolus, and they don't stay lateral malleolus, medial malleolus. We are more posterior, and this way we don't have any problems with anatomical structure. Now we fix it, the wire, and the half ring should be in the middle. You should look it from the bottom and to understand, because you don't put the rings like this, not like this, but it is the shape of the half ring repeated the shape of the calcaneus. And we may stay near because posterior part it's not so volume, don't have so big volume. We may stay maybe minimum 1 centimeter from calcaneus, because calcaneus never have so big swelling posteriorly. In this way, it's the frame more stable. Near you stay, better is. Okay. I fix it. Okay, I put in attention. Okay. Okay, we maintain this position inclined because we need to correct. And now what we do, we put the pre-drilling or You
Facciamo direttamente con la pin?
yeah, possiamo fare directly because here in the calcaneus the bone really soft. We use this or with penetration, or we use sometimes the 5 millimeters half pin. And in this case we put the 6 millimeter half pin. One, we have a half pin fixation bolt. Yeah. Okay. We'll see. Yes. We hope that the bone osteoporotic because it's not unloading. Quite big half pin. This one. Sì, tu come sei posizionato? I'm still thinking. Dammi rondella grande. Now we put this olive wire, but with half pin fixator, and I want to stay below the wire, and I put here one washer. And we continue like this, and I stay below. Okay, like this. Inclination is okay. We don't do pre-drilling because it's soft bone, it's going really fast, really good inside here. And remain stable. Okay. And fix it. Okay. Now we put another one from the medial part. Mm-hmm. Yeah, put on. Okay.
Ho visto il chiudi trapano per caso?
Cos'è?
Grazie.
We do this. No, stai un po'. No, posteriore. Sì, fai ancora un po' più posteriore più facile. Okay, we need to find the good inclination to take the big piece of bone, quite posterior. We don't do never exactly posterior because of the attachment of the Achilles tendon. We stay just a little bit lateral from Achilles tendon insertion. Yes, quite easy to use 5 millimeter half pin. It depends on the size of the patient, of the foot. Okay. What we do now we leave this calcaneus in this position, and normally in the operation room, what we do, we proceed with open surgery. But quite better, maybe, I don't know, we don't do this surgery, better before applying the calcaneus Hafrin to do just surgery on the least frank joint, open surgery, fix it in a good position. Here, obviously, if we do surgery now, our forefoot falls down on the floor. We will do this procedure, this osteotomy, at the end of the surgery. But in real life, we'll do it open surgery before applying the frame of the foot. But only for the technical details, I show you how we do this. In osteotomy, we do later. Now we should apply the frame on the forefoot, and we show you how we attach, how we do the connection there. No, facciamo dopo. No, because if not, it will be difficult. Yeah. No, it will be difficult now. If you attach this, the forefoot we can do. Okay. What we do, the application of the frame of the forefoot. In this case, we want to use 3 wires, and I see many people use wires in perpendicular position of the axis of the foot, because it's easy to apply the frame, it's easy to attach the ring, but we need to follow the anatomy of the foot. And for this reason, what I do, the first wire I put in the proximal part of the 5th metatarsal, a little bit from posterior and a little bit from the plantar, in the large part, and this wire go on the base of the 1st metatarsal in oblique way, because the least frank joint in the oblique. And we do like this, and this wire may penetrate quite all of the metatarsals and really became stable wire. Like this. And see, we are fortunate here, we put all of them. Huh? Repeat. No, it's a little bit slow. Oh. Go forward. Like this. Okay, this is the first wire. The second wire we do opposite side, from the 1st metatarsal to the 5th distal wire. This wire is just not so easy to put all of them, and usually we prefer to catch always 1st and the 5th, and sometimes we take 1st, 5th, 4th. Not easy to catch the 2nd and the 3rd, because they are have a arch transverse arch of this, and not easy to penetrate all of them. We try to do this, a little bit elasticity we have. Alza ancora qua, aspetta, ripetirò, giro un po'. Okay. We don't catch. Okay, 4th and the 5th. Okay, that's good enough, stable enough. And after that, maybe we may put another wire, 3rd wire, for more stability. Olive or no, without olive, not important, without olive. in here. Maybe I'll try to put it in the third and the fourth just a little bit more dorsal. Okay, and this third wire, and like I explained you, we don't look about the position of the ring, we look about the, pay attention about the anatomical area of the metatarsals. And after that, when we put this wire, we adjust this half ring, and the half ring should be exactly perpendicular of the axis. The wire is not perpendicular, but the half ring should be. It looks from here, look from here, and usually we prefer to put it perpendicular of the axis of the forefoot in this, in lateral view. Okay, like this. Okay, we attach this for first. We may bend it just a little bit if you want. Okay, attach this. Here, we attach this. Yeah, we use the bolt, and we use many times washer and the post to attach them. And this is like a three-dimensional fixation. Here we should leave a big space because usually dorsal part of the foot is swelling too much. And another thing, we should push the forefoot down. For this reason, we should leave a big space between the dorsal superficial of the foot and this half ring. Okay, now we do it just a little bit more like this. Okay, bolt. Okay, attach like this. Now we should decide how to do the tension, and I think I need to fix this wire. Keep it, Filippo. And this, in forefoot fixation, we don't use the tension of olive wire in a opposite position like we do in the tibia. Because if you do the tension of olive wire from here and another from here, what's happened? The olive displaces a little bit and they squeeze it metatarsal. It's not good for us. We want to maintain a good large position between them. Okay, in this way now I tied this from opposite side of olive, and Filippo later do the tension of this olive wire. I need the post now, maybe 2 holes male. 2 holes male here. Okay, nut. I need another one, maybe 4 holes.
4-3.
Ah,
Vuole 4?
no, 4.
4.
Yes, 4.
Telecamere di filo.
Ah, 4 holes. We use this because we need more longer here. Okay.
in piegafili, supplier.
And a slotted bolt. Okay, thank you. We attach here.
Tu uno.
Okay. Now I fixed the ball of this post. Okay, strong fixation. Okay, I wait now the Filippo. Put this. Oh no. Ah, mail? No, caduto. No, devi mettere
Tiro io,
troppo poco, no, ma comunque troppo.
quello non c'è il filetto. Non c'è, basta.
Ma non è. Questo è la mela bassa? Un maschio basso?
No, alto.
Alto. Possiamo usare femmina. Ok. Now we adopt this. Okay, the bend just a little bit wire because during tension the wire displaces it a little bit distally and it's take this original position. Okay.
Io devo tensionare questo.
Huh? No, posso tenere io. Tight and I tension from my side. Okay. Perfect. Yes. Okay, 1 second, I cut it. And now we do the tension of this wire from the medial part. The first wire that I tied from my side and the tension will be done there. Okay. Perfect. Filippo. Oh, may. Yeah, my tension both of them. Fix it there.
Bandierina da
No, you may put the post or not, or it's enough space. If it's possible, put it. Okay. Good. Okay. I do the tension of the wires again. I have to explain before this. Here we don't need to tension too much because the wires, if you do a big tension, the ring may be deformed because it's not complete ring. We do a little bit less tension than usually, maybe less. Like this, it's enough. And another one.
So the degree of your bending will decide the tension for
Yes,
this, I
yes,
guess.
exactly,
You know.
exactly.
Maximum you could do probably 60 degree.
Maximum is 60. No, you may do it more, but it will be not so good tension of the bolt inside.
Okay.
Okay, now like you see, the rings exactly perpendicular of the forefoot, in this position, and we know it's stable, it's not, don't move. A really good fixer.
So during the surgery, you fix that ring first before you osteotomy, or
No. Usually we do in all this foot osteotomy or orthodesis before applying the frame.
Okay.
Now we can do this here
Yeah.
because it's unstable.
Yes.
But in any case, now we repeat it. Maybe we do our surgery, we cut the bone, and we fix it with the Kirchner wire. We have it some kind of saw or? Yeah, actually. Okay. That's, now we do this. We do, like I said, open surgery. Two approach, one lateral, one medial, because I never did again the plantar approach. I don't know, maybe in the future, but not now. Yeah, we do.
It's a directed approach. It's actually, I use it
Yes.
a couple of times. It works, has
Okay.
its advantage.
Makes
but
sense.
Yes, makes sense.
I'm
But
just worried about that neurovascular bundle.
yes, neurovascular, but then after that, in any case, the scars from plantar. One time, I remember foot surgeon said, "No, never do approach plantar
Because of pain.
because of pain.
Never have pain.
They don't
You
have pain."
resected that ulcer, the bad skin out
Yeah,
from
yeah.
that approach. Actually, it's a pretty brilliant approach.
Okay. Okay, we did it. Now, what we do usually after surgery, when we do this approach, I try to correct it by hand, and we put it now with the wire to keep it in the right position. Okay, like this. It's okay. This is interfragmentary wire. This only temporary wire fixation. No. One second, we'll see. Ok, facciamo così. Go like this. Stop. Okay, it's enough. Okay, we fix it like this. No, it's enough. It's so just temporary wire. Okay, what we do now? Accorciamo questi fili. We cut it for simplify our job. Okay. Okay. What we do now, like I explained you before, the first thing that we should realign the rear foot. What it means, we need to put the calcaneus normal position. We remove this wire. We need it if there is a really fixed contracture of the ankle joint. We do a lengthening of Achilles tendon, but if it is possible to do without big difficulties, we don't do Achilles tendon lengthening. Because what we do this kind of correction, acute correction, immediately, and we need to put it practically 2 rings, distal ring on the tibia and the half ring of the calcaneus. We may put them parallel. We found the holes that corresponding, plus minus. It's not so important here. There's only connection. Okay, one here, another for me here. I may put it posteriorly because I put the plate probably. It's not so difficult to connect, like you see. And again, I notice it's here with big volume of the soft tissue. Here not, in calcaneus. For compensate this difference of the position of the ring, we use a plate, posterior plate. Not. Okay, this 2 rods tightened, and I put another one again here. I will find the corresponding holes like this. If you don't find it, it's always easy to use a plate. Use here. Important to have 3 rods because these 3 rods guarantee the good stability. 2 rods not enough. Okay, I use small.
Cioè se no c'è quello più piccolino.
Oh, bene. We use this, connected where we have holes, comfortable positions, like this. Here, not geometry here, not so important. I put it oppositely and a little bit much more posterior because I need, I may use these holes on the anterior part of the half ring. And we don't need no more correction of the calcaneus because we do it in the surgery acutely. I correct it. We attach it, and now calcaneus stable, and we achieve a good position. Like I said, this ring, it is 80 degrees of the axis of the calcaneus. When they are parallel, the calcaneus now in the right position. Another thing we should do now, you see again, our least frank joint is reduced, but not completely. What we do here, we build this hinged frame, like we show here, and we show you which kind of connection we do, because in this way, we may adjust it during surgery as maximum as we can, or if you want, if you have some problem with the skin, wounds, etc., you may do it a little bit progressively in a post-operative period. Okay. In the foot, the regular number 1 that we need to have always biplanar hinges. Always biplanar hinges. It's like cardanic hinge. It's like a ball and socket hinge. But we don't use ball and socket. We use Ilizarov classical biplanar hinges.
So you can use that hinges for distraction or compression?
Distraction, compression, or anti-correction, varus, valgus, supination, pronation, all of this movement. How we do this? I put this male. We put one male here.
We went to just a basic frame to
Okay. Tight it? Okay. Now we need this this post. We use it like a hinge, but we need the biplanar. What we do, like I show you here. One.
Quali? Queste?
And another one, another male.
Donne e meno?
Okay. What I mean the biplanar hinges. This is biplanar hinge. Because it moves like this, and another one will be in the road, which sorry. Let's see. Yeah, we put maybe long one 150.
Okay.
And here we need two female post. Female we attach to the rod here. Tight the nut. And we attach here to the male post. Never use a straight rod, never use only one hinge. Because what we need, we always need in the food this kind of movement, you see, like this. Advantage of this system that we may use it always or we may tighten it. If I want to block it, I may block it in any time. You see now it is not moves. I block it this, it is not moves. When I want to move it, I relax it and it hinges always. Okay. And these two rods, now we position them. This is a plantar rod, and they should be parallel to the plantar fascia of the foot. Tell me. Cubetto anche a me questo punto. Ok. Okay. Okay, look here now what we did. We did these two rods, the lateral and medial. They may do lengthening, shortening, and we correct the abduction or adduction of the foot. And we may do compression if we want. And we may correct the cavus deformity or flat deformity in this case. What we do now, I keep the foot. Now I don't need this wire because it's difficult to reduce completely our foot. Remove this, please. Remove. Togli la mano qua, non lo vede. Okay, we remove it, and now what we do again a good correction of the foot. Remember, it was like this, and we now should create the cavus or normal position of the forefoot. We use these two rods. I keep them in the right position, and Filippo, my assistant, now create the connection here. You know, maybe we may do it internally. Yeah. Remove this. Yeah, we put it externally, but here in this case we may correct it, or rotate, and put it in internally. much easier to connect in this way. Okay, like this. Okay. What we do here again, like a regular number one, always biplanar hinge. And I show you this one. Because now we connect here. This is a male post. And this post may rotate like this. Because if you lose this, it moves like this. And we correct abduction or abduction. And this hinge permits me to correct the cavus deformity. This way, now obviously this permits the same time to do lengthening or shortening. Now we build the same connection laterally to whole male post. Here. No, one or two. No, mettiamo due. Two holes. Again.
Se vuoi c'è il 3.
No, non c'è due. E mettiamo uno con rondello. Se no femmina. Femmina con bel... sì, due fuori. Here. Okay. Bolt, short bolt.
Short, short or
Short, short.
perché ciccia è la... Ah, va bene.
Sì, sì. Okay, and now you see we correct it like this. We fix now maybe a little bit more. They should be parallel, or in any case, it should be corresponding of the foot position. If you do foot position, like this. Now we tighten them a little bit, and they fix it temporarily. We tight all the connection now. This hinge is non-function now. Okay. And what we need again, we need to create this kind of connection, anterior part, because we need two rods here, and these two rods permit us correction of supination and pronation of the forefoot. Okay. We put this. Always one rod with female, one post female. One hole, female, post.
Ancora un altro.
One here. No.
Vuole nel bullone?
No, we put this, no, one male, one post, one full male.
Sì.
Ah, yes, I have one. Oh, give me one, I give one other one, Filippo.
Questo è alto, sì.
Okay?
Ce l'hai tu, Phil?
No, aspetta, prima metti maschi. Okay, what we do here, and again we create biplanar hinges. One hinge here, you see it may rotate here. If we release this, it's rotated. Another hinge here. Like you comfortable, we may touch like this or like this. Displace it. And now we need the plate. Here we do the big lengthening. I think maybe if we do it shorter, because like you see, when we correct it, It is became too long. We need to put in a good position. Okay, we do shorten. You see, these two rods permits me now to reduce this dislocation. I short here, and then now the foot in a good contact. Okay, now connect it here, Filippo. No. Connect the first. Oh God. Castrato. Castrato. Lo stacco. Okay. And we put this two rods one by one. We use the plates because the plates we have different size. You know, there is this one, longer one, shorter one. We adapt it in how we want. Okay, we fix the plate, and now I attach another one.
No, no problem.
Cade.
Ce l'abbiamo.
Okay. Okay, and we adapt my rods with the plate.
Ci va o vuole quella più lunga?
Più lungo. One or more.
Yes.
Okay.
Grazie. Oppa, così.
Sorry. Another bolt and another nut. Okay, now it's much better because the frame became much stable, more stable. Nut. Okay, what I do, I fixed again my plate here, and I show you how it is functioning. You see, practically, like I explained you, this is one. Do you hear me? Do you hear me? I don't hear. Guys, I want to explain you. Guys, sorry, guys. I want to explain you how it is function this frame for correction, because like a sublime before that, we need to use always biplanar hinges here. This is hinges for correction, pronation, and supination. Okay, now we'll show you better here. Okay. Well, this hinge and this our hinge. What I do here, now I may use all of these hinges. This, I may use it for correction, pronation, and supination like this. Now we may lose everything. All these hinges will be free. And the distance. Okay. You see how it moves. It moves completely, but we may control it by hand how we want. And what permits me to do this? Permits me to do lengthening in these two rods. And I correct cavus deformity. This system you may use like this or like this. In this way, you correct pronation or supination of the forefoot. And the same, these two rods moves. You see, they incline it because they have all the hinges. And when we finally see that the position of the foot is satisfactory for us, we tight all of them, tight all of system. Yeah, and we fix it in the position we want. Okay, we tight all of them. And obviously we do it acute way, and we achieve the really nice position of the foot. Maybe we need to do more, like you see maybe now this is just a little bit displaced at planetary. What I do correction here. And I fix it. And this is acute way of correction. We finished practically our surgery and everything. But if you find in the later, in the control, that you want to do any kind of correction, if you need to do compression of the wrist front, you may release this and compress here, and you achieve more compression on the joint if you need it, or medial or lateral more. If you do this not simultaneously, maybe more compression in this one, you correct adduction or adduction. If you do more compression here, your foot goes like this. If you do more compression lateral, your foot is in abduction. In this, you may play with this rod. In this rod, you may play to do the correction of the cavus deformity or flat deformity, and the pronosupination depends on how you use this rod. Finished. Now we fix it, and the surgery finished. Okay. Thank you for your attention.
Thank you very much.
Okay, finish.